we're going to switch now into the relapse refractory setting. And the relapse refractory setting, obviously this is something that's very important. 80% of the relapse, not 80% of patient relapse, 80% of the relapse occur within the first 18 months, and they're really challenging. High-dose therapy, salvage and high-dose therapy and auto was the standard of care, and the patient we know that fail early do very poorly. One of the questions that comes is that we are starting to understand better the molecular diversity at baseline. What becomes this molecular diversity and what molecular factors matter to predict the outcome in the relapse setting? Greg?
So it's a very interesting question. So what we found, for example, that cell of origin, which is predictive of the outcome of the initial diagnosis, appears to be not as prognostic at the time of relapse. So relapse seems to be an equalizer of the outcome, at least for cell of origin. Now, there's more and more data emerging in terms of the molecular clusters and how they look at the time of relapse. And as you would expect, some of them are enriched in certain mutations. But at this point, apart from maybe double-hit lymphoma, there is really no clear-cut evidence, to my knowledge, that any of those molecular subtypes would have a worse outcome in a relapsed refractory setting. All those patients relapse early, unfortunately, have relatively poor prognosis.
Peter, what's your take on how you manage those patients that are relapsed large cell lymphoma? Obviously, it depends when it happened.
Yeah.
How do you manage them?
I mean, I think Greg is on the money, and that's sort of the old dictum of the proof of the pudding is in the eating. If somebody has chemotherapy refractory lymphoma, the fact is chemotherapy didn't work, and we have to look outside the standard toolbox. I think historically, standard second-line therapy has been rice at our institution. You know, the CORAL study suggested that potentially our DHAP would be better in the germinal center subtype, and so occasionally I've done that. I admit that anecdotally, I don't feel like there's a huge difference. We have at our institution a clinical trial with selinexor and rice, and I think that other institutions have done similar trials in that space, and we'll hear more about CAR T cells in that space, and I think that clearly there's a need for improvement.
This is definitely a population that is a challenge still, right? And then it depends if the early failure, primary refractory, or early failure within 12 months do very poorly. Even if they go into PET negative after salvage, typically they still go for an auto, but this is not the majority, this definitely the patient. So, Dr. Chavez, how do you manage the patient when they have an early relapse?
And early relapse.
Early relapse.
The early relapse are very challenging. You know, the Scholar data show like the overall response rate is about 25-26%, and CRs less than 10%, and the overall survival is about 6 months. So this is a very poor prognosis patients. So what we usually recommend is consider a clinical trial. You know, one of the important clinical trials that actually recently completed enrollment was the SUMA-7, and then we're looking at seeing if we can improve the outcomes. But in the absence of a trial, unfortunately, there is nothing other than the standard of care.
SUMA-7 for our audience, we should mention that this is a CAR T cell approach versus a salvage therapy, and
Exactly.
in order to go to an auto, and then obviously if they fail the salvage, they're going to go into a CAR T commercial for the SUMA-7.
Exactly.
In other studies that cross over.
Exactly. So, so it's a very challenging population, and in the absence of trials, so we kind of recommend the approach of the standard salvage chemotherapy. If the patient had a chemosensitive disease, as soon as possible, we can send it to autologous transplant. That's probably not the case for double-hit lymphomas. If double-hit lymphomas is early relapse and it had, we get into that point on a remission after salvage chemotherapy, we typically consider an allogeneic transplant.
Sorry, go ahead.
Yeah, and I just want to add one thing to that. So in early relapses, especially patients that are primary refractory, I always try to repeat a biopsy. So sometimes you can learn additional things, especially if that first biopsy was needle only. In these patients, as you mentioned, they don't do well. So I'm looking for things like CD30 positivity. I'm looking for ALK status, and obviously checking for MYC if it wasn't done in the front line, because that could potentially inform, what I would do next with regards to salvage.
Sure.
That's a great point. I think, You know, sometimes you find things that are totally unexpected. We did a biopsy of somebody who had a diffuse large B-cell lymphoma, and one area wasn't getting better, and he had a Merkel cell cancer. You know, I think it's absolutely an excellent point that if something's not responding, make sure it's what you think it is.
In general, we biopsy all relapse, but in general, probably this is not done enough.